Hi, good evening, everybody, and greetings from India. This is evening here. I'm sure some places it's night and mornings. From people are from all across the world. They are all listening to us. So this is one of the very important topic in sarcomas. This is Dr. Pramod Chinder. I'm an orthopedic oncosurgeon, head of orthopedic oncology and director HCG orthopedic oncology and the yellow ribbon. So we have, this is from Bangalore, India. We have our eminent panelists with us. Dr. Abdul Rahman is a consultant medical oncology, Fakib University Hospital, UAE. Dr. Akhil Kapoor, assistant professor medical oncology, Tata Memorial Hospital, Varanasi, India. And the next panelist is Dr. Arun Shahi, senior consultant, MBBS, MD medical oncology, MPH epidemiology, Patan Academy of Health Sciences, Nepal. Welcome, Arun. We have Dr. PS Dattatreya, consultant, medical oncology, Renova Hospitals, Hyderabad, India. Welcome, Dattatreya. We have Dr. Makhsud, MBBS, MD medical oncology and PhD, consultant medical oncology, Akfa Medicine, Uzbekistan, Tashkent, Uzbekistan. Welcome, Dr. Makhsud. Dr. Shafatujjahan, head of the department oncology, Chattogram Ma O Shishu Hospital, Medical College, Bangladesh. And we have our own Dr. Vidya Veldore. She is the driver of this talk. She has been the head of genomics of 4 Base Care, Bangalore. She, I know her since 12 to 13 years now. We have been working on a lot of genomic work in sarcomas. She is extremely well versed with the genomics, that I can say. Sometimes as an orthopedic surgeon, she teaches me from the basics of genes to, orthopedic is like ECG read by an orthopedic surgeon. So something like that. But yeah, she made me understand a lot of genomics on that. So with that, I will start this program today. The program flow will be like this. At the beginning, Dr. Vidya will give the basics of sarcoma genomics and how the way to reach the sample to the lab. Essentially, that's the clinical person's defect. All the time, the difficulty is how to send the sample. So that is what she's going to highlight on that. Followed by me, I'll talk about a few cases and the way we approach from the orthopedic surgeon oncology perspective. And followed by all the other panelists, their opinion regarding the sarcoma genomics in the matter of diagnosis, therapeutics, prognosis, and the future in genomics. So we have everybody's take on that. And Dr. Arun has one case report on that. And at the end, we'll have a question and answer session, depending upon the time availability. So let's go live. With this, over to you, Dr. Vidya from 4 Base Care.
Thank you so much, Dr. Pramod, for this kind introduction. And I will start my presentation. So to quickly wrap up what we know in sarcomas, primarily classified as soft tissue and bone sarcomas. Bone sarcomas constitute close to 13%, and the rest of it is soft tissue sarcomas. And most of them have diagnostic gene fusions. What we know in genomics of sarcoma, primarily sarcomas are tumors which are derived primarily from gene fusions. And here we see on the right hand side, liposarcoma has some of the classical gene fusions. Angiosarcoma, as the name suggests, is primarily driven by VEGF receptor and its oncogenesis. Then leiomyosarcoma involves a classical PTEN loss, and then rhabdomyosarcoma is driven by PAX genes, PAX3 and PAX7 regulation. Ewing's, it's very well known and it's been known for a very long time. It's driven by Ewing's family of genes, EWS, and the partner changes. Synovial sarcoma is again a very classical phenotype, which is driven by gene fusions involving 2 major gene classes. Now, what we know in terms of sarcoma genomics after the advent of next-gen sequencing, on the right-hand side, we have the latest, publication from ASCO that talks about what is the spectrum of genes which are often mutated across sarcomas. And there are quite a few targetable biomarkers which like KIT, FGFR1, and KRAS and IDH1, and the future is there to explore. As we know, based on NCCN guidelines today, we do not have single gene, single biomarker kind of a story so far being well established in sarcoma. However, we have tumor agnostic biomarkers. I will come to that. In sarcoma, primarily the role of sarcoma and treatment till today is driven by surgery. And if surgery is not an option, then it goes with chemo and radiotherapy, whether it is a locally resectable disease or metastatic, depending on the requirement, making the quality of life better, which Dr. Pramod and other speakers would speak about it. In bone sarcoma, this is a major classification per se, where you have a neoadjuvant setting and where you do not have a neoadjuvant setting. Then challenges in management of sarcoma today. Sometimes if it is a deep inside lesion, sometimes it gets a late diagnosis, and it's a highly heterogeneous disease, aggressive nature, and current chemotherapy options that we are having, not many tumors respond to it effectively like a curative approach, and often there is a recurrence. And sometimes there is also a differential diagnosis based on the histopathological examination, which again brings a lot of confusion to the clinician who is treating. So what we know in E-wings today, as I mentioned earlier, E-wings fly is a major fusion. However, there are other genes which are mutated, and some of them have a role in targeted therapy. There is some role of few biomarkers which are a part of the BRCA and HRR genes, and some work has happened, and also there is some clinical trial which is supporting olaparib, which is open currently from the clinicaltrials.gov. And this is another complete summary which we recently pulled out from clinicaltrials.gov as recent as yesterday, to understand what are the biomarker driven targeted therapy options today open in E-wing sarcoma, to see what best we can provide based on the mutational spectrum of the disease. This again suggests that there is a role for looking at molecular profiling in E-wing sarcoma to see if the patient is particularly in a recurrent setting, if we want to try something after all the options are exhausted in a trial mode. So synovial sarcoma, as we all know, it is driven by SYTSSX gene fusion. However, there are other molecular alterations that are present. But when you look at the biomarker-driven therapy trials, we did not find anything significant that has been very well established today in therapy domain. In osteosarcoma, the classical ones are TP53, CDKN2A, and CDKN2B. And beyond that, there are other genes which are mutated, but to a lesser extent. And then it's primarily, it's a very, very, I wouldn't call it a heterogeneous malignancy, but there is no, common driving force like E-wings or synovial that this is the underlying alteration. In GIST, there will be a case study presented by Dr. Arun in the subsequent session. But primarily, just as we all know, it is a KIT PDGFR driven tumor. And sometimes we do have RB1 and CDKN2 and CDKN2B alterations being noted. And beyond the classical KIT kinase domain mutations and PDGFR mutations, KIT expression is also noted and by IHC, which is also one of the important aspects, and BRAF rarely though. And this is again a summary of what are the options available in clinical trials in GIST. And most important, this is not very old, the succinate dehydrogenase family of genes, which is important to understand the role of response to TKI. And tissue agnostic. So as and when there was a tissue agnostic, one of the very early tissue agnostic biomarker is microsatellite instability. in the year 2017. And subsequently, there was tumor mutation burden. And then we had NTRK fusions. These three biomarkers are tumor agnostic, and hence it applies to sarcomas also. And the most common sarcomas that we have seen in the routine clinical practice is fibrosarcoma, angiosarcoma, and ovarian clear cell sarcoma recently. And role of immunotherapy, we don't have much to say in immunotherapy, classical immunotherapy, but most of it is in clinical trials in very early stages, CAR T cell therapy and vaccine-based approach. And so what do we have? So based on the cancer cell properties, there is so much to explore and understand what works and what does not work for the patient. Some of them are clearly biomarker driven, but if you look at this class of drugs, these are multi-kinase inhibitors, so it is very difficult to say whether it is a biomarker screening is really required or not. Again, on the immunotherapy front, we need to look at different clones to address which one would work essentially. And another important area where there could be some improvement is PARP inhibitors. And so where are we in terms of, as we move on in understanding the role of sarcoma? I just summarized there. And I'm going a little fast because I've been given 10 minutes now. This is a small work which we did with Dr. Pramod. The reason I am putting up here is there is a big value addition of fresh tissue taken at the time of surgery and preserved in RNA later that improves the diagnostic yield to close to 100% in terms of looking for genomic alterations, and that will help us in a better clinical management of the disease. Wherever possible, it is always good to look at fresh tissue. I'll come to it in subsequent slides. This is just a small summary of our findings. We are still working, this is work in progress. And we found some important actionable alterations, which are again not directly related to sarcoma, but we found the driver mutations in this group of sarcomas, which were either osteo, Ewing's, and giant cell tumors and synovial sarcomas. And we found, well-known gene amplifications also being documented here. We have the VEGF amplification, MAP kinase amplification, and these two genes are together being co-amplified in osteosarcoma. There should be some role to play there. And there is some path, based on the pathway approach, there are few drugs which are available in clinical trials, as mentioned here on the right side. Then we have the other tumor suppressors, and there is a KIT amplification, which is also noted, and this is documented in literature. And gene fusions, there were umpteen number of gene fusions. Some of them were at least one evidence of reported in literature is available. We have 44 different gene fusions that we identified in this cohort that we screened for. Now, sample requirement, this is a general overview, diagnosis, pathology, then molecular testing. So classically, FFPE is the tissue and the gold standard methodology to look for any molecular testing, extract the DNA and then gene sequencing. Here we take fresh tissue and RNA-later. It is stable, this RNA-later is stable at room temperature, and it can be stable without any tissue for several years. And once you put the fresh tissue from the surgery unit into the vial, it is stable at room temperature for at least a week. And then after that, it is stable at 4 degrees Celsius, that is in the lower compartment of the refrigerator for a month, and indefinitely at -20 or -18. So there is no hurry that there is a fresh tissue, it would get autolyzed or it goes into some kind of necrotic problems or any other issues. As soon as that tissue is there, the moment we put the recognize that it's a malignant tissue, we put it into this, then we can act upon it slowly to reach the lab within 48 to 72 hours, so that the next process of work can be initiated for genomic profiling. Disadvantages, we don't look at histology here. We primarily go by the surgeon's eye or the pathologist's eye. Gross examination. So what are the challenges? Why this story is being shared here? Common challenges with bone and soft tissue sarcoma. Sometimes the location where you try to take the biopsy would come with a bony component. And when there is a bony component, it goes through decalcification. It results in heavy degradation of both DNA and RNA. And
last minute, Vidya.
Yeah. Yes, done. This is a very important aspect. And so it severely gets degraded to an extent that even a single gene testing for PCR or Sanger or real-time PCR becomes impossible. That is where you have the role for tissue being sent in RNA later. And our efforts, even before we offered this option to Dr. Pramod and his team, we did a parallel analysis between tissue versus fresh tissue versus FFPE for few samples, and then we have ensured that we are getting similar molecular alterations in both the approaches, so we are not losing on the diagnostic yield. However, at the same time, we are making sure that the failure rate comes to 0%. So again, as I mentioned in the previous slide, the same thing has been summarized here to make sure that we get the maximum benefit out of the next-gen sequencing. I think this is it from my side. I would be happy to take questions later. Thank you. Pramod, over to you. You are on mute.
We will take the questions at the end of the session. Is it okay with the other panelists, or would you like to finish this? I think
it's okay.
It's okay.
Yeah.
I think you're right, sir.
Yeah. So we'll go with the next presentation of our experience with in orthopedic oncology and the genomics. You can see my screen. I think you should unshare. Dr. Vidya, can you unshare the?
I already unshared.
Okay, fantastic.
Yes.
Okay. So you can see my slides, everybody?
Yes, we can see. Please go ahead.
Very clear.
Yeah. So good evening again. So we will start with our experience in orthopedic oncology. So this is from Delhi Ribbon and HCG. So we all know the sarcomas, all the story of its heterogeneous, and what we know is only about few sarcomas with Ewing's synovial sarcoma, chondrosarcoma, rhabdomyosarcoma, and GIST is the main thing what we focus on, though we are hunting for quite a lot of other things. So in such a scenario, most of the times our work happens in Ewing's and osteosarcoma. In genomics wise, it's Ewing's and synovial sarcoma. So we know all this translocation, it is published, written everywhere, but these are all mainly, we are using them mainly in diagnostic purposes. Definitely it helps a lot in when you have a confusion between Ewing's and osteosarcoma certain times, and synovial sarcoma for sure in many times. So we have seen many oops surgeries and wrong treatments without diagnosis properly, and where the genomics has helped in a proper diagnosis. So I'll just briefly run through how we work up as a clinician. I'm sure all the clinicians do the same way. From the orthopedic oncology perspective, we make sure the clinical history is taken profile very high on a very high note because of the complexity of malignancy. Workup as X-ray, MRI, PET, CT. The last thing is the biopsy, tumor board, sarcoma tumor board, and further on. Most patients nowadays are advised for genomics testings. So as we go, once the malignancy is tested, we will go into the next step. Just as there's a network issue, I think. You can all hear, right? Okay, so we go to the next.
We can hear you, Dr. Chinder.
Yes, there is some buffering. 1 second. Yeah. So
your far left, you can see that you can press on the button, can help you easier.
yeah, this button is somehow, you can see my, no problem. Anyway, so this is the protocol what we use for the osteosarcoma. Most of the times osteosarcoma is the MAP protocol and Ewing's is the other way back and IE. So I'll just briefly run through one case example. This is Harsh, one of the patients which we diagnosed with an Ewing sarcoma with a pathological fracture. And we did the standard work of non-metastatic case, essentially curative intent. We did go ahead with the proper cytogenetics and everything, and it turned out to be all the things positive, even the EWS FLI1 positive. So this is the diagnosis followed by VAC-IE regimen. Then the chemo, the PET scan shows almost a very good response in this case in a non-metastatic Ewing sarcoma. Almost the SUV is nil. So later on, once the chemotherapy is done, we go ahead with the limb salvage surgeries. In this case, we use what is called as a functional reconstruction following the resection of the tumor. That's we remove out all the neurovascular bundles, all the muscular attachment and insertions, and separate out all the neurovascular bundles along with the muscle insertions, so that you have functional hand. You remove the tumor en bloc, and at the same time you reconstruct. Here in this case, we used a reconstruction with an allograft. Allograft as in a fresh frozen allograft. We use the brain dead donor's fresh frozen allograft tumors. This is after the reconstruction. So this is how the post-op sequence goes. He finishes the chemotherapy and he's on the follow-up. So most of the times we achieve about 70 to 75% of the cure rate in a non-metastatic Ewing sarcoma. So the next, coming to the case one, considering the genomics perspective, on a similar case intent, this gentleman this boy is a case of a Ewing sarcoma of the proximal tibia. He did not have any family history. Then we worked him up standard way, started him on a neoadjuvant chemotherapy. If you see this slide, on the left side, it's a pre-chemo and right side is a post-chemo. The size started increasing during the chemotherapy. So what made us think that this is not going to respond? So we also added a intra-arterial chemotherapy. That is cisplatin we used intra-arterially. Then so that as the tumor was increasing even with VAC-IE, so we thought we'll change it to intra-arterial. So then we took a decision after 6 cycles, we removed the tumor en bloc because it was not responding as a standard measure. Then we removed it en bloc tumor excision. Then within a matter of next 1 week, not 1 week, about I think 1 month. So the tumor started recurring everywhere. That means in the distal thigh, in the distal leg, in the lymph nodes, in the lungs. It started mediastinum just in a matter of a month and a half. Because we were wondering why the wound is not healing. There are some swellings. Initially we thought it was a function, it is a pus. So then we did a genomic testing and an onco-sensitive report called OncoPrint. So which shows what is going to respond. So then in that case, this showed actually there was a slide I think which was saying. So this case showed a mutation which is not a standard mutation of EWS FLI1 translocation. It was not a EWS FLI1 translocation, and there was a lot of heterogeneity in the translocations. So this boy died in the next 4 months. He did not survive. So essentially, looking back, we thought one, he was not fitting into the right age, that it was at 21 years. Number two, he was not responding to the chemotherapy, though it was non-metastatic. And number three, he was with the genomic testing, he was not a classical translocation. So essentially, with the help of genomics, we sometimes what we predict that 70% is the cure rate in Ewing sarcoma in a non-metastatic case. Sometimes can go bonker like this case. So that is what one lesson we learned from this case. This is an Ewing sarcoma of the proximal tibia. So the next one is the proximal, the Ewings, not Ewings. This was a 43-year-old gentleman who presented with a mass in the right ileum. Upon workup, he was a metastatic from the beginning and was diagnosed to have a undifferentiated high-grade pleomorphic sarcoma. So we started him on with all the immunochemistry markers and everything. We started him on the neoadjuvant chemotherapy. During the workup, we found out that his family had a proband. I mean, he had a family history. I want to explain this. Yeah. So he had a family history of sarcomas and other cancer like breast cancers. So when we did the pre-genetic test pedigree chart, we found that he had a family history from his paternal side, that his father's brother had expired or diagnosed to have a brain cancer. So followed by, then we counseled the patient. Then I happened to get deep into the history. Then he said his cousins, his relatives, a lot of them were having it. So then we dig deeper and found out that he was having a lot of people in his family. If you see the post-genetic test pedigree chart. So then we found out there was some similarity of the sarcoma and the breast cancer and the brain cancer. So with all these things, we suspected that he may have some kind of a genomic alterations. Then we found out that we did a P53 analysis and we found out P53 was mutated. And during the process, during the counseling itself, we happened to see a very bad, I would say, progression of disease in one of the family tree. So that is one Leigh-Fromini syndrome we found out in our case. So through Sanger sequencing, and we did a genetic counseling with the other relatives, closed door according to the NCCN guidelines. So we did counsel them about the early screening methods for the breast cancer and other, like with early lifestyle changes like headache and orthopedic oncology on the whole body MRI sequencing. So all these things we made sure that they were people who were at risk were screened at their family. So this is another case which we happened to find out during the course of our treatment, which was helping the other family members to make sure that they are picked up very early and treated accordingly. So this other case scenario which helped us. Likewise, we had other, in most of the cases, it is more of diagnostic utility and very rarely in the treatment utility so far. Diagnostic wise, in myxoid liposarcoma, essentially synovial sarcoma, as we discussed, and yesterday Dr. Arun was telling it's about GIST. We don't see them much. So this is what our clinical utility of the genomics in summary. Thank you very much, and this is our team which helps us in getting through the things done at the Yellow Ribbon, Bangalore. Thank you very much.
Thank you.
Thank you.
So,
Dr. Pramod, can we go back to that case number second? Can I ask a question, or should we ask it at the end?
I'm unable to hear anybody.
Hello, can you hear me?
Hello, you can hear us?
Yeah, I'm hearing you. What about you?
This is our 10-minute presentation of work. So next we will ask Dr. Arun that he has a small presentation about his work with genomics in sarcomas. Arun, over to you.
Yeah, thank you. Thank you very much.
Dr. Arun, you wanted to ask a question?
Yeah, I wanted to ask a question to Dr. Pramod.
So can we take the question at the end, everybody? Is it okay? I think, is it, how do you say?
No
Because
problem.
I don't know. It's okay. We can ask the question. That's no problem. Go ahead, Arun.
No, I wanted to ask about the case number 2.
Yeah.
That guy who progressed on VAC-IE.
Yeah.
You guys gave the cisplatin intravesical, right? Or like you can say.
No, we added it. We added a cisplatin intra-arterial.
Intra-arterial. So
Yes.
like, what is the ratio about responding with that? I mean, after adding intra-arterial cisplatin.
No,
like
not much. In this
other
case,
experience, because that guy did not do the good. Like, what made you use that medicine? Is there any evidence, scientific evidence, or is there any article published, or what was the reason behind that? Why did you use that medicine?
Yeah. No, I understand your question. See, intra-arterial we generally don't use, but we use when there's a mass is big volume. Of course, there are a lot of papers from MD Anderson. So we use papers, we use the intra-arterial only in the massive tumors and some tumors which behave like this, they did not respond in a regular fashion. So in the third cycle, we added this intra-arterial. Otherwise, not many cases we use intra-arterial. We use intra-arterial only when it's a big disease. We want to do an R0 resection and we want to hit it hard in the beginning, like that, such cases.
And do you have any other success, stories with that, adding that?
Yes.
How many cases?
No, we have
because if you have a success case, we can encourage our musculoskeletal oncosurgeons in Nepal to use that as well. Because
no, it's the only thing is it's a intensity with the procedure where you need to have a good interventional radiologist. So that's the only procedure. And at the timing of the injection of the cisplatin or any drug, we use a hyperthermia along with the cisplatin.
Okay.
So we'll explain.
Yeah, the question why you use cisplatin and doxorubicin is localized disease. We know doxorubicin probably has more activity than cisplatin as intra-arterial, especially in Ewing sarcoma. So the question would be why cisplatin and not doxorubicin? That would be probably his question, or my question would be.
And that my medical oncology, I am not too. I do not know. My medical oncology suggested me.
No.
Yeah.
Which I'm sorry. Which regimen you used before the intra-arterial?
VAC-IE.
VAC-IE.
That's fine.
Yeah.
So thank you.
In that case, I was trying to ask that as the chemotherapy was not working in that case, we could have tried for a preoperative radiotherapy.
Yes.
Usually, if we could apply some of the preoperative radiotherapy, the tumor should have shrunk a bit. Then we can go for surgery, and then we can add a salvage therapy subsequently. That should be an option. I don't know if you agree with me.
I agree with you, especially it's a localized disease, no metastasis at the time. Systemic chemotherapy did not work. Intra-arterial chemotherapy did not work. It is better to control the disease for a better surgical margins, and then later on. I agree with the trial of radiation therapy, high dose even though, as because can chance go with a high dose and hoping, though the data is not much clear for that, and we know that Ewing sarcoma is from day one, once you diagnose it, is metastatic eventually. So we know that the disease will come back, but we're hoping to control the disease at the site.
We did think about radiotherapy in the tumor board, only on the question that of the resectability with R0 margins, and number two, whether I could operate after radiation in the proximal tibia area. Proximal tibia area is a difficult area to operate post radiation, and also I could do the R0 resection. Was the two things. We have done a preoperative RT in many sarcomas, around the proximal thigh and proximal limb, where our dissection makes it more nicer for us to dissect.
Right. But nowadays it's proven that preoperative radiotherapy, not in only sarcomas of different sites, actually for some cases of rectum, where radiotherapy is very sensitive, but for big tumor, but a patient who is not capable of taking any neoadjuvant chemotherapy, we also used radiotherapy, and we waited at least 8 weeks also sometimes to take the real margin for R0 resection. And we can wait for that long also in between. So it is just my opinion that as we are waiting for that time after radiotherapy to get a good margin for surgery and to get the tissues available for surgery and healing, so we can apply this also in sarcomas also.
Okay, good. So with from coming to the genetic perspective, Dr. Arun, you have a few slides, right? Did you manage to get the slides, Arun?
You're muted, Dr. Arun.
Can you see my slide?
No, not yet.
Not now.
Now can we?
Yeah.
Yes.
So thank you for Care for this opportunity, and it was really indeed a great pleasure to meet all the experts from the different part of the world. And this is kind of like good exposure as well as good experience. And I heard from the Dr. Pramod, it was really good. I mean, cases, and you guys are doing really very good. And I mean, like, so in Nepal, I work in a Patan Academy of Health Science. It's a deemed university. We have so many. We have undergraduate students, postgraduate students. We have a school of nursing, public health. So all this. And the good thing about our center is like we have been getting this free drug for few cancers, CML, this GIST, lung cancer, few lung cancer, ALK and ROS1 positive, and then renal cell carcinoma. We have been getting this medicine for free. Basically, like we have more than 1,200 patients of CML patient and almost 350 patients of the GIST patient since last 5 years. And so the GIST patients are like, we have a like low grade, intermediate grade and high grade. The low grade and intermediate grade, they are responding very, nicely, and their overall survival and PFS is very good with the imatinib. And in this last 5 years, I have recently seen one new cases, which is like, which I did not see before. Even during my residency in Bangladesh, I did graduate from Bangladesh at the National Cancer Institute. In that is, I think, one of the biggest cancer institute in South Asia. Like, due to the population of Bangladesh, we have almost 500 or 600 OPD patients in medical oncology ward only. So there also I did not see. So I would like to share one interesting case. There's a there's a 50 years female, and she is non-smoker, non-alcohol. There is no family history of cancer in her family. And then she complained with the abdominal discomfort for last 1 month, and also loss of appetite for another 15 or 20 days. Then she came to see the general surgeon, and then they found out, they did the ultrasound, and they found out that there was like 10 into 12 centimeters a lump in the abdomen, and that was in the hepatic flexor area. So then there was a tumor board, and then they did the biopsy, and then the biopsy showed that it was positive for exon 18 PDGFRA mutation. And then since the protocol, like NCCN, according to the NCCN guidelines, if it is resectable, we have to resect in the beginning. Like just so the surgeons, they thought that they would be able to do the R0 resection. So they went for the surgery, and they did the R0 resection. Then again, after the surgery, we thought like it was a gastrointestinal tumor from the histopathological report. So we thought like we have to confirm the diagnosis. We sent for the IHC, and IHC showed that it was the exon 18 PDGFR mutation. So now I want to ask my medical oncologist colleague that if there is an exon 18 PDGFR mutation and it was CD117 and DOG1 was negative. So in this kind of patient, like how do we proceed? Because there is a R0 resection. Should we opt for the adjuvant therapy or we go for the observation only?
If I may, regarding just, that the decision to go for an adjuvant therapy for 1 year or for 3 years depends on the characteristics of the tumor. If you respond as a high-grade tumor or low-grade tumor, there's a specific table for the criteria. And if you deem that this patient is a high risk, yes, you should go for adjuvant imatinib for 3 years and not only 1 year. So if you can show us if you have the data about not only the mutation, about the size of the tumor, the location of the tumor, the mitotic value of the tumor, it can help us to categorize if the patient is a high risk or not. And if it's high risk, for sure you should go for adjuvant imatinib.
Very frankly speaking, like I asked them to put that histopathology report, and right now they did not add in my PowerPoint. But what I can
I think that if there is R0 resection,
yes.
So CD117 is negative, only
yes.
surgery is enough there.
Okay. But the patient is fit, the equals performance status is 0. But there are some literature showing that if there is exon 18 positive, in that case, we can go for avapritinib. I think you guys know about that. So should we wait and watch or keep in a active surveillance or give avapritinib?
Actually, we need the total histopathology report. Actually, we should see the mitotic count and the margins and the grading. All of these depends, and then we can take the decision whether should start the adjuvant or not.
Okay. So what if it is a low risk or intermediate risk, and what if it is a high risk?
No, if it is a low risk, in that case, we can wait and watch. But if it is intermediate or high risk, as long as we know that there is a deletion of exon, so we must start any of the adjuvant for maintenance, only for, for protection, like 1 or 3, as our doctor already said. If it is intermediate or high grade, we must give some adjuvant.
So, and there is another confusion regarding the imatinib or avapritinib, because if CD117 and DOG1 is negative, should we again think about
if it's exon 18 is the mutated, so I think it's better to use like a non-small cell lung cancer, all the TKIs.
Okay. Okay, so I mean, there's you can see in the screen that all exon 18D842 mutants, they are like imatinib resistant. So avapritinib is not available everywhere. So what, according to our tumor board, we have kept that person, even that is intermediate grade tumor. So we are searching for this drug, avapritinib. Is it available in your country?
No, it is not.
No,
not available, right?
No, it's not available.
So based on that, we have, we have kept that patient in active surveillance. So I just wanted to show this thing. Let's see, because this is the recently diagnosed patient. So maybe after 3 or 4 months or 6 months, I can again share the progress. So I just wanted to share this thing. Thank you very much.
Thank you, Dr. Arun. Dr. Abdul?
Yes.
Do you have a comment on the sarcoma and genomics? Over to you, Dr. Abdul.
Yeah, for sure. For Dr. Vidya, regarding the issue of the genomics, it's well, we tend to from now on, because of the science becoming advanced and the cost of the test has become more affordable, and the results are becoming much easier within a week, maximum 10 days. So we're trying to do a whole exome sequencing on all patients at diagnosis, metastatic or non-metastatic disease. And what we're trying to do, something if we can advise on that, we're looking into the idea of as you said, there's difficulties sometimes of getting the real mutations from the bone, but soft tissue is usually easier. The role of liquid biopsy concomitant with the role of tissue gene sequencing as an addition to what we have to, just to reiterate on the data that we might have from the tissue biopsy. But also we know that from other solid tumor who are, high grade more than sarcomas, but actually for the circulating tumor cells, that we can look at the probably the dominant or the driving mutation for the metastasis in order to decide on treatment right now and the future. Like we know that the tumor cells who tend to metastasize usually probably have a different gene mutation or a driving mutation than actually just the tumor. So we tend to test for both of them. So what do you think about the concept of doing that for every patient at diagnosis, metastatic or not, at least to predict or to try to set a future plan from now in the future from that?
I totally agree. Yeah, Dr. Vidya, what do you? Yeah.
So definitely there is a very important role here, and we are currently offering combined molecular profiling for tissue and liquid biopsy in our laboratory, and we already have seen couple of cases where liquid biopsy has given value addition. We just started around 3 months ago, and there are cases where there were a few driver mutations which were not present in tissue, but we could pick it up in liquid biopsy, particularly at the time of recurrence or during the disease progression. And just before you think about the next line of treatment, that is the right time when you are going for a re-biopsy to look at liquid biopsy together. Because I had a slide with me, we all know about it. When we go for a core biopsy or any other method of sampling a tumor tissue, we don't address the complete tumor heterogeneity. All malignant cells need not carry all the clones that we want to see. There would be few clones which are present in certain locations, but not in some other locations. So when you do a liquid biopsy, not just from the primary site or a specific metastatic site, even from the micrometastatic lesions and distant regions which are not even at the resolution of a PET scan imaging, that is less than 1 centimeter or 1 millimeter nodules, there also there is driver which gets into circulation. Those tumor cells release the DNA, and actually that helps in giving the holistic picture for the disease. So one example is a cholangiocarcinoma, which was NRAS mutated on tissue. Patient was started on Folfox, and after a year he developed a disease progression. And it so happened that at the time of diagnosis, this patient was treated elsewhere, and he had happened to go through a whole exome sequencing, both tissue and liquid. And so when they came to us this year, just about 2 months ago, they provided us the previous data. So it became essentially a follow-up sample. So we thoroughly looked into it, and we went at high deep sequencing, more than 5000x coverage. And we found out the patient had a FGFR2 pathogenic alteration, which is known in bladder cancer. And today we have FDA approved drugs for that. But it happened to be present in a cholangiocarcinoma, which came up with disease progression. Therefore, what I'm trying to say here is, as we understand more and more, the medicine is turning more and more towards genomic. It's becoming a molecularly driven approach to understand the disease along with the clinical phenotype, of course. And if there are no guidelines, it becomes a N of 1 clinical trial after patients' families' approval. If you don't have any other standard of care options. But this is a example which gives us a information and a hope to the patient that if all the lines of standard therapies are exhausted, there is a driver that can be attacked.
Thank you. But I would like to ask my colleagues now. Let's say we have a tumor, sarcoma, metastatic, and you use all the standard of care, and you did again an NGS or exome sequencing, and you found a driving mutation which has a drug, but this drug has never been used or tested in a clinical trial for a patient of sarcoma. Would any of my colleagues give this medication to this patient, or would you follow the MDT again and check you get approval of MDT, or you do not even mention the presence of such a drug?
I think it's very prudent that we always complement all the diagnostic procedures which we have. And as you rightly mentioned, the best approach would be to always go through the MDT, because then one brain but is much inferior to multiple brains working on one issue. I'll prefer that the MD should be involved so that the whole team is involved in the care, and that will possibly be helpful. Now again, usually in these patients, time is not running out. So a couple of days after the report, but an MDT approach is preferable. And I completely agree with that, Vidya, that to always understand that tumor heterogeneity plays a very big role. And so solid biopsy and liquid biopsy are complementary to each other. Thank you so much, sir.
Yeah, with another question, I say MDT, I agree totally with you. We go to the MDT, MDT is going to give you a decision, multiple brains better than one. But then again, there's the medical legal issue. You have a patient who needs a drug and you tell him that there's a drug, but it's not for you, but it's for the gene mutation that you have. But when you go to MDT, it's not easy for everyone to say yes and no for something that is not approved or not even tested on this. So how can physicians, as are we, going to decide on a drug that was not even tested, even though the gene mutation is there for this patient? So this is something really difficult. You cannot convince all physicians, because whatever we take, there's also medical legal behind it. The patient, if he have any complications, he's going to come back to the MDT and say, why did you approve it?
So my take will be like, in those kind of situation, we also discuss with patient party or patient. And also we also look for the price of the drug, whether it is affordable or not. So if it is very affordable, there is evidence of the gene mutation. In that case, with the permission from the MDT, because we know that even in one forum, everyone will never, all of us will never agree. There will be some difference in ideas. So in that scenario, we'll just look for the risk and benefit and discuss with the patient party, and then affordability. If there is all is in favor of the patient, then we can also start those kind of medicine.
Thank you. Thank you very much for the thoughts.
Fabulous. So,
Dr. Makhsud, you had something to share in the previous case?
No. I'm just hearing and a lot of information. It's
okay.
It's okay, everything.
Yeah. Thank you.
Thank you.
so Dr. Shafa, do you have any comment on the sarcoma and genomics? I'd like to hear from you.
Okay. First, I would like to thank you all and for Ways Care for inviting me and allowing me to with you all. Actually, in my case, I would like to say, as a radiation oncologist, I am practicing here. We have lots of obstacles in Chittagong. Though we are trying for all the patients, but all the patient cannot afford to do the NGS and the genomic profiling and everything. But after some point, we all are bound to go for that point, that we should go for NGS and other molecular profiling to go for further treatment. As we know, the sarcoma is not a good one, and to treat or to radiate. So I encourage everyone, and I learned a lot about the profiling and the genes that are driving changes in our treatment and protocol. And we also, one thing I forgot, I wanted to ask you all that, are you using the extracorporeal radiotherapy in your centers?
Yes, very much, very much.
We are not.
It is very promising.
Very useful.
Yeah, very promising. And it gave us a new hope for the treatment and limb sparing like this. And I enjoy very much when I get the patients. I already have 3 patients who were treated with extracorporeal radiotherapy, and they're doing very great.
Very good. Yeah, likewise, I think the sarcoma treatment is a global approach rather than an individual approach. We have to learn from a lot of, we get support from Italy to Japan to my friends across the world to send the allografts or the fresh frozen allograft or we did a liquid nitrogen from the friends from Japan. So it's ERT. So it's like, I think it's the overall, because it's a very small world of sarcoma. I think it's better to learn from each other.
Yeah.
So next,
there's questions from Dr. Sharma. He's here on the messages. There's questions. He has some questions if anyone would like to answer.
Yeah, should I go ahead with the questions?
There is one from Dr. Akhil Pramod. Dr. Akhil had a comment to give.
Dr. Akhil,
he raised his, yes, Dr.
please.
Akhil.
Yeah, hi. So again, thank you for having a very great discussion about a topic which is very, very difficult in the real world scenario. I'm a medical oncologist and I see cases with advanced sarcomas. And when we are discussing the cases in our BST joint clinics, it is very important to have a comment from our multidisciplinary team. Because sometimes when the patients are borderline resectable, it becomes very important to have a comment from both medical and radiation oncologists so that our surgical colleagues can do a better job for excising the tumor completely. Apart from that, when discussing about the advanced tumors, when the only treatment is systemic treatment, the key is to utilize the NGS panel, which includes all the important sarcoma markers. Because what is happening, most of the NGS panels do not include relevant sarcoma genes which are important for action. But what is the take-home point from my side, always select NGS. It should not be a blind NGS. It should not be a shooting in the dark. You should know what you are looking for and include the relevant sarcoma panel. For example, I always try to discuss with my molecular team to include the panel which would include the genes for the sarcoma. For example, when I raised the requisition for an NGS for a patient, I got a call from my molecular team that this panel will not be good enough for knowing all the sarcoma markers, sarcoma genes. So please change the requisition. So that is what is important. So involving your molecular team in your discussions is important, especially while treating with advanced sarcomas. Thank you.
Thank you.
So we'll go to the questions, no?
Dr. Dattatreya, sir.
Yeah.
Doctor.
Yes, madam.
Sir, you have something to share on your experience in sarcomas.
There is some lag in the network.
So let's go for the questions at least to finish. We're running out of time.
Yeah, we'll go to the questions. Would it be an addition to look for metabolic signatures in sarcoma and not only genomics?
So as has mentioned, I think I completely agree with the previous
Okay, for the first question, so anyone else to answer the first question would be in addition to look for the metabolic signatures in sarcoma and not only genomics.
Dr. Vidya?
Not that I know of in terms of metabolic signatures.
Not to my information.
Yeah.
So the second question is for me, Dr. Pramod. Would electrochemotherapy have been a good addition for local treatment in a neoadjuvant setting as you have used intraarterial chemo? So electrochemotherapy is another different ballgame altogether, according to me, because it is used mainly in a case when there is not resectable, because you're going to poke the sarcoma in many areas. And I mean, generally, I don't like to do that. That's only probably for fungating sarcomas we have used in 2 or 3 cases. Without much of experience in that, only as a trial we used in 2 to 3 cases, but I don't have much experience.
It's more beneficial, I see, in palliative. And you want to control pain, you want to control size, more palliative than actually as neoadjuvant.
Correct. So the next question is, what are the major reasons for reoccurrence of tumor or cancer? Dr. Abdul, you can take that.
Well, actually, most likely because actually the disease already has spread before doing anything, but it is at the microscopic level that we cannot recognize it. And that's why now the technology is moving to look into the circulating tumor cells, such as in colon cancer, breast cancer, and soon it's going to be lung cancer. So the disease has already metastasized, but it's not clear in images. So that's probably, and for sure, metastatic cells have more power to spread and adhere than the others. So that's most likely the cause.
The fourth question we already answered. How liquid biopsy NGS test is efficient for sarcoma? I think we discussed about it.
Yes.
Fifth question, TP53 mutations in sarcoma is mostly prevalent. Does it have any predictive and prognostic relevance? How it helps in real world clinical practice? We just highlighted the same answer in our case scenario. TP53 mutations in a family history, what we experienced in a multiple family history had a predictive and prognostic absolute relevance, because we could predict during the workup itself, a girl of 18-year-old was diagnosed to have a brain tumor, and in the next few months she expired. So that is the predictive capacity of the genomics of TP53 things in Liframini. And I think Dr. Vidya or anybody can take this call. I think TP53 have a lot of people have a lot of experiences.
Yeah, it's predictive to that more resistance to the medications and less survival as prognostic. So that's the main thing.
In the context of somatic, right?
Yeah, somatic for sure. And it can be, I'm not much into germline P53, but yes, clearly might correlate the same.
Sarcomas are mostly fusion driven. Have an advantage, FISH and PCR over NGS. Which one would you prefer?
I'll repeat the question. Sarcomas are mostly fusion driven. Are FISH or PCR testing have advantage over broad and comprehensive NGS? Which one would you prefer? Vidya,
well, if you want to diagnose the case, diagnosis, you use FISH and PCR. But I think if you want to expand, I think you go for the NGS. And right now it's probably cheaper to go NGS than actually doing everything. Because FISH, you need to use 1 probe or 2 probes. PCR, you have to be very specific also. So I guess going for NGS for a whole will be much better and cost effective.
Yes. And also you will have the advantage of looking at umpteen number of partners, which is not at all cost effective if you go with a sequential testing like EWS Fly1, EWS WT1, EWS and several other partners. All these come into Ewing's class. So Ewing's partners, which is known partner itself, there are about 9 to 10 partners, which is very well documented. So it is not easy for us to know the corresponding partner in FISH. You only know what, or sometimes that is in the breakup approach. There is another approach which is, as you rightly said, predetermined. You know that you are only adding Ewing's and Fly probes. Then you know only you are going to detect if that particular translocation is present. Whereas in NGS, the floor is open. Anything that translocates with Ewing's, and you will know the junction boundaries where exactly it goes in for a break point, then you know that the disease is driven by this tumor. The major factor what we look at the molecular level is the partner is the transcription factor, and it has the DNA binding domain which is responsible for oncogenesis. So the fly1 is the partner here, and that drives the disease essentially. So there is the advantage, I would say.
Yeah. There are 3 more questions. I think it's already, time is up. We have 6 minutes past 6. I think we can respond to them if they can later, at the later date, later time. Anybody from the floor or any one of you has got anything to say before we wind up the session? Of course.
No, thank you for the invitation and to a very fruitful discussion. Probably, you know, if we're going to meet again, is that
I would love
we
to
show what we have as data, as genomics, and how our genomic testing was translated in real life to show that actually it is beneficial to go through the genomics at early or even when the patient is metastatic. So this would be a really interesting to see, because as you can see, the data is very scarce regarding the targeted therapy in sarcomas. And one of the questions is, as you can see, is the failure of checkpoint inhibitors, because alone maximum gives 24% response. But I think the future is the combination of checkpoint inhibitors with kinase inhibitors probably to help. So that would be my suggestion.
Or like in lung cancer, where chemo plus immuno is working. You never know if there is a clinical trial with chemo-immuno combination.
There's doxo, there's doxorubicin pembro, there's doxorubicin. There is a lot of trials, but the problem is that in sarcomas they put them all together. They need to put each type of sarcoma alone and each type of specific driven mutation sarcoma also alone to show the benefit. Most of the trials were actually basket style, that all types of sarcoma for one treatment. That's why most of the trials failed to show the benefit.
Yeah, I think as a group, Vidya, you should probably in the 4-base care, you should have a genomic bank, like how we have in sarcomas. Yes, we did for 40 cases in your this one. I think we are all the way supporting. From my tumor board, all the cases have to have gone for genomics. So I think that at least in the next few years, we should have at least a concrete way of, you know, at least predicting some bad things or predicting some good things for our patients. That's from my clinical perspective, which I've been always fighting with Vidya. Yeah.
So why don't we together join all the data that we have and try to publish something regarding genomics and sarcoma? I think this would be a good idea. There's many papers I know, but I think as long that now we met each other and we know each other, and then each one we have data, why not we start making a review, comprehensive review, mini review, whatever you want to call it, about the genomics and its implications on clinical practice. So I think Dr. Vidya, she can be our as I say, moderator in this paper, and we can start writing from now.
Yeah,
sure, definitely.
Yeah.
Very happy to hear that this session is helping this kind of a discussion, and sharing knowledge in a platform like this is going to add value.
Makhsud,
yes.
Makhsud, you have something to talk, Dr. Makhsud?
It's the NGS is the very young testing procedure at this time, and so your information, it's very important for the last papers, because there is no information by the NGS and treating by the NGS results. You are giving on your results, you are giving only the FDA approved drugs or on the trials like that, but there is no information clinically on the trials, what it worked or not. There is no information by the trials, by the FDA approved. I mean, after the NGS testing, it will be great idea. It's great idea to working further.
Exactly. That's what exactly.
Right,
Makhsud,
right,
exactly.
right.
That's what we should do. We already met together, and I think we should start from now. Whatever the case we had in the past and the future, and I agree with Dr. Makhsud that would be a more impact paper whenever we have such data. Agree totally.
Sure.
We are with all of you.
Thank you very much. Thank
Yes.
you. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you all.
Bye.
Bye.
Thank you.
Thank you.
Thank you.